This video is for educational and informational purposes only and should not be considered professional coding, medical, or legal advice. Welcome back. This is Module 2 of our Medical Billing and Coding Certification course, and this is where the real work begins. In Module 1, we got the big picture, the revenue cycle, the 3 code sets, the certifications available to you. Today, we're going to zoom in on the most foundational of those code sets. ICD-10, CM, the International Classification of Diseases. 10th revision, clinical modification. I want to be honest with you. ICD-10 CM can feel overwhelming at first. There are over 70,000 codes and a whole set of official guidelines that govern how you use them. But here's the good news. It's organized, it's logical, and once you understand the structure, everything else clicks into place. By the end of this module, you'll know how ICD-10 CM codes are built, how to read the tabular list and the alphabetic index, and how to apply the most critical coding conventions that appear on every certification exam. Let's get into it. Here's what we'll cover today. 6 solid topics. We start with the anatomy of an ICD-10 CM code itself. Before you can assign codes, you need to understand what you're looking at, how these codes are built, what each character means, and what the maximum length is. Then we'll cover the 2 reference tools you'll use every single time you look up a code, the alphabetic index and the tabular list. There is a specific, required workflow for using these 2 together, and getting it wrong is one of the most common mistakes new coders make. Third, we'll go through the official coding conventions, the instructions embedded throughout the ICD-10 CM manual that tell you when and how to use certain codes. These include notations like includes, excludes 1, excludes 2, code first, and use additional code. You will see these on your exam. Fourth, we'll dive into the Section 1 guidelines. These are the official general guidelines that apply to all settings. Fifth, sequencing. Knowing the right code is only half the battle. Knowing what order to put them in is equally important, and there are rules for that. And finally, we're going to code 3 real cases together. No better way to learn this than by doing it. Let's go, starting with code structure. Let's look at the anatomy of an ICD-10 CM code, how it's actually built. ICD-10 CM codes are alphanumeric and can be anywhere from 3 to 7 characters long. Let's use the code on screen as our example. S52001A. The first character is always a letter. It tells you which chapter of the manual you're in. In this case, S puts us in Chapter 19, which covers injuries, poisonings, and certain other consequences of external causes. Characters 1 through 3 together form the category. S52 is the category for fracture of forearm. Character 4 adds more detail. It gets into the specific anatomy or etiology. In our example, the 0 at position 4 means upper end of ulna. Characters 5 and 6 add even more specificity, site, laterality, whether it's displaced or non-displaced. Character 7 is special. It's called the 7th character extension, and it tells you what kind of encounter this is. A means this is the initial encounter, the first time the patient is being seen for this condition. D would mean a subsequent encounter, a follow-up visit. S would indicate a sequelae, a late effect or complication from a previous injury. This 7th character is critical. Many students lose points on their exams because they forget to apply the correct 7th character. And in real-world coding, submitting with the wrong character can cause claim denials. The key takeaway here: ICD-10 CM codes have meaning baked into every character. You're not memorizing random codes. You're reading a structured language. Okay, now let's talk about the 2 tools you'll use. Every single time you assign an ICD-10 CM code, the alphabetic index and the tabular list. Think of these as a 2-step process. You cannot skip either step. Step 1. The alphabetic index. This is organized alphabetically by the name of the condition, disease, or term. It's your starting point. When a patient presents with, say, type 2 diabetes, you go to the alphabetic index and look up diabetes, Under diabetes, you'll find subterms, type 1, type 2, with complications, without complications, and so on. The index narrows you down to a code or code range, like E11 whole. Now here is the most critical rule in ICD-10 CM coding, and I want you to burn this into your brain right now. Never assign a code based solely on the alphabetic index. The index is a guide, it's a roadmap, but it doesn't contain all the instructions. It doesn't show you the includes notes, the excludes notes, the code first, or use additional code instructions. Those are only in the tabular list. Step 2. The tabular list. Once the index gives you a code to look at, you go to the tabular list, which is organized numerically by code, and you find that code section. You read the full entry, you check all the instructional notes above and below it, and then you select your final code. In our diabetes example, you'd find E11 in the tabular. Look at the options under it, check for any includes or excludes notes, and confirm that E11.9, type 2 diabetes mellitus without complications, is correct for your patient. 2 steps. Every time. No exceptions. This is one of the most commonly tested concepts on the CPC exam, and it's a real-world best practice that protects your provider from compliance risk. Now we're going to talk about the official coding conventions, the instructional notations you'll find scattered throughout the ICD-10 CM manual. Understanding these is non-negotiable. They will appear on your exam, and they affect real-world coding every single day. Let me walk you through the 6 most important ones. First, includes. When you see an includes note under a code category, it's telling you that the conditions listed there are considered equivalent to or part of that category. These conditions belong under this code. Second, excludes 1. This is the one that trips people up the most. Excludes 1 is a pure exclusion. It means the 2 codes are mutually exclusive. You cannot ever use them together on the same claim for the same patient. If you see an excludes note, those conditions cannot coexist under this coding scenario. Third, excludes 2. This one is more nuanced. Excludes 2 means the excluded condition is not part of this code, but it can exist at the same time in the same patient, and if it does, you can code both. Think of excludes 2 as not included here, but may apply separately. Fourth, code first. When you see code first, it's telling you that the underlying disease or cause must be sequenced first. The code with this notation is a manifestation. It comes second. This is the heart of etiology and manifestation coding, and we'll practice this. Fifth, use additional code. This is an instruction that says you must add a secondary code to capture the full clinical picture. It's not optional. If the guideline says use additional code, you use it. Sixth, code also. This indicates that 2 codes may be needed to fully describe the condition. The sequencing depends on which condition is primary or most severe. I want you to go back through these 6 after this module and quiz yourself. Write out each term and explain it without looking. If you can do that, you've got the conventions locked down. Let's talk about sequencing, because in ICD-10 CM, the order of your codes matters. Insurance companies and facilities use that first code to determine payment, clinical categorization, and data reporting. Getting the sequence wrong can mean a claim denial or underpayment. The rules differ depending on whether you're coding for an inpatient or outpatient setting. So let's break down both. For inpatient settings, hospitals and facilities, the governing term is principal diagnosis. Here's the official definition, and I want you to know this word for word. The principal diagnosis is the condition established after study to be chiefly responsible for the patient's admission to the hospital. Notice that phrase, after study. This means you may not know the principal diagnosis on day 1. The patient might be admitted with chest pain, go through testing, and be diagnosed with a pulmonary embolism. In that case, the pulmonary embolism is your principal diagnosis, not the chest pain. And yes, the principal diagnosis can, and often does, differ from the admitting diagnosis. For outpatient settings, Clinics, physician offices, urgent care. The term is first listed diagnosis. This is the condition that, after study, is chiefly responsible for the outpatient encounter. One critical difference for outpatient: you do not code probable, suspected, or rule out diagnoses in outpatient settings. If the doctor isn't certain of the diagnosis, you code the sign or symptom instead. This is the opposite of inpatient, where you can code probable or suspected conditions. This distinction, probable diagnoses in inpatient yes, in outpatient no, is one of the most frequently tested points on the CPC and CCS exams. Mark it in your notes right now. All right, theory is great, but coding is a skill, and skills are built through practice. Let's code 3 real cases together right now. Case 1. A 58-year-old established patient presents to the office with uncontrolled type 2 diabetes and diabetic chronic kidney disease, stage 3. Okay, what do we have here? 2 conditions, the diabetes and the kidney disease. Step 1. Go to the alphabetic index. Look up diabetes type 2 with kidney complications. The index points us toward E11.65. Let's verify in the tabular. E11.65 is type 2 diabetes mellitus with hyperglycemia. Good. Now notice that under E11 in the tabular, there's a use additional code instruction for the stage of chronic kidney disease. So we must add a second code. N18.3 is chronic kidney disease, stage 3. Our final answer, E11.65, N18.3, diabetes first, then the kidney disease. Case 2. Patient in the ER after a car accident. Closed fracture of the shaft of the right femur. Initial encounter. Index. Fracture, femur, shaft, right. Points to S72.301. Now in the tabular, we need a 7th character. A for initial encounter for closed fracture. Final code, S72.301A. Case 3. This one is an outpatient visit. Patient has persistent fatigue and weight loss. The provider documents possible lymphoma. Yes. On to be evaluated. No confirmed diagnosis. Remember our outpatient rule? We do not code possible or probable diagnoses in the outpatient setting, so lymphoma is off the table. We code the symptoms instead. R53.83 for other fatigue and R63.4 for abnormal weight loss. 3 cases, 3 different concepts. The etiology, manifestation rule, the 7th character extension, and the outpatient probable diagnosis rule. These are all exam-tested scenarios. Excellent work! Let's bring Module 2 home with our key takeaways. 1. ICD-10 CM codes are 3 to 7 characters long, and every character has a specific meaning. Category, anatomy, severity, and encounter type are all encoded in the structure itself. 2. The 2-step lookup process is non-negotiable. Alphabetic index first, tabular list second. Never ever assign a code from the index alone. 3. The coding conventions includes excludes 1, excludes 2, code first, use additional code. Govern how and when codes are applied. These are not optional guidance. They are official rules embedded in the manual. 4. Sequencing rules differ by setting. Inpatient, principal diagnosis. Outpatient, first listed diagnosis. Know the difference. 5. In the outpatient setting, you never code a probable or suspected diagnosis. If the provider isn't certain, you code the symptom. 6. 7th character extensions are required for injury and fracture codes. A for initial, D for subsequent, S for sequela. For your Module 2 assignment, complete the conventions worksheet. Code 10 practice scenarios using your actual ICD-10 CM manual and read through the first 25 pages of the official Section 1 guidelines. I know reading guidelines doesn't sound glamorous, but those pages contain everything that's tested on your exam. Module 3 is next, and it's a big one. CPT coding. We'll get into evaluation and management codes, surgical CPT, and modifiers. See you there.